I want to introduce tonight's speaker. Dr. Ronald Gross is a medical director at large with the McSwain Trauma Education Project and the McSwain Charitable Trust. His career in trauma surgery includes time at Bridgeport Hospital as Associate Director of Department of Trauma at Hartford, as a Chief Division of Trauma, Acute Care Surgery and Surgical Care at Bay State Medical, as a Senior Member of the Division of Trauma and Acute Care at Surgery at St. Francis Hospital. In 2021, he was recruited by UPMC in Williamsport to assist with the growth of their trauma and acute care surgery service and to mentor surgeons and PAs during the growth of their program there, culminating in their verification as a level 2 trauma center. He's a clinical professor of surgery in the Department of Surgery at the University of Pittsburgh Medical Center. He returned to St. Francis as a senior member of their acute care surgery room in 2022. Dr. Gross also volunteered for service in the United States Army Reserve Medical Corps in 1988, achieving the rank of colonel, and served as chief of staff and chief of surgical services for the 405th Combat Support Hospital. He deployed to Iraq, was honorably discharged in 2005, and invited to participate in the Distinguished Surgical Senior Visiting Surgeon Program at Landstuhl Regional Medical Center in Landstuhl, Germany. This is a very sought-after post, and a lot of people that wanted to go didn't get to go. Ron was one of the ones that got to. The program is a joint effort of the COT, the American Association of Surgery and Trauma, that brought these civilian surgeons to work in Germany side by side to military surgeons. Dr. Gross is a member of the Massachusetts State Trauma Committee. He's held the position of vice chair and chair of the Connecticut State chapter of the ACCOT, and he was a member of the National ACS-COT from 2008 to 2018. A lot of this period in here, when I was running the ATLS program, meant that Dr. Gross was talking to me at 2 o'clock in the morning to help me find x-rays when I was trying to get the book done. And he was a great help to me then. He's an original author of 3 ACS courses, ADAM, which is the Advanced Trauma Operative Management course, and the Disaster Management Emergency Preparedness course, or DMEP. Also with Advanced Surgical Skills for Exposure to Trauma, or ASSET, an editor of the first edition of ADAM course, served as chair of the ADAM Operative Management course from 2015-2018. And he's co-editor of the 8th edition. In any case, he was also instrumental in the Stop the Bleed program, which has become a national thing. In all, as you can see, he's been very active across the trauma field and has always been dedicated to EMS and the fire service. And you can see that a lot, particularly if you see his activities through social media and the other things that he's been acting on. Most importantly, I'm proud to say that Dr. Gross has been run as a friend of mine, and I'm glad that he joined us on these projects that we're working on and that you guys get to hear him speak tonight. So without further ado, I'm going to turn it over to Ron. Let him have it.
Will, thank you very much. I hate to say it, but your introduction is longer than my talk. Y'all didn't need to hear that.
I tried to edit it, but I thought I couldn't do it.
No, well, I am thrilled to be here. And in the interest of time, I'm going to try and share my screen. I'm going to warn you all that computers and I don't get along, so keep your fingers crossed. Hot damn, I did it. All right. Now, oh, what's this? There we go. All right. So first of all, again, thank you guys for allowing me to do this talk. Thank everybody who is on. I hope that what I have to say today will give you a little bit of hint about how far we've come in pre-hospital care. I will admit that this subject is a passion of mine. EMS is a passion of mine, and so let's move forward. There we go. For a minute, I got nervous. It wouldn't let me do anything. Let me get this out of the way. I have no disclosures. Well, actually, that's not true. I have always considered myself to be a partner to our EMS providers, and if that's a disclosure, that's one that I'm very proud to be able to talk to you all about. Now, horses to horsepower. What got me going on this topic? A very long time ago, actually in 2003, was an amazing talk by Norman McSwain. Norm gave the Scudder oration on trauma in 2003, and he was talking about pre-hospital care from Napoleon to Mars. Norm actually discussed all of this dating back to the Egyptian times, but mainly the last 4 centuries. And for those of you who don't know or aren't familiar with the Scudder oration, this was presented to the American College of Surgeons Clinical Congress, as I said, in October of 2003. Charles Scudder, interesting fellow. He was born in, of all places, Kent, Connecticut. He's one of the founders of the American College of Surgeons, and he's actually the first chair of the American College of Surgeons Committee on Trauma. So to be a Scudder orator is an amazing honor. And in the last, I don't know, 30 years or so, some of the names that you guys will recognize are Norm, Ernie Moore, J. David Richardson, Tommy Thompson, David Hoyt, Brent Eastman, Dave Feliciano, Demetriadis, Fabian, Mayer, Schwab, Meredith. The list goes on, but to be a Scudder orator is an amazing honor. And it was appropriate that Norm received that. So let's move back about 400 years. Hard to say, but I am amazed. It's 400 years. Those of you who know the name Dominique Jean Larrey. Larrey was one of Napoleon's surgeons, and in fact, he was the director of Napoleon's medical service. And for a year or so, he took a look at what was going on with Napoleon's army as they moved through Europe. And the quote at Lemberg, "The remoteness of our ambulances deprived the wounded of the requisite attention." He was therefore authorized to construct a carriage which he called the flying ambulance. Now, it was not unusual for the entire conflict that soldiers were left in the field for 7 to 10 days, often with absolutely zero medical care. And what this guy did is he put together this double horse-drawn carriage, which, as you can see, was fairly luxurious. It was enclosed. It was easy to get the patients in and out. It was associated with trained medical personnel who actually went forward to the battlefield, controlled hemorrhage, transported these people to the nearest hospital, i.e., a field hospital, provided care en route, and had these hospitals move forward with the troops. Sound familiar to all of you who are prior service with any of the services? This sounds vaguely familiar, doesn't it? Kind of makes you think about the forward surgical teams and the combat support hospitals. So Larrey was hundreds of years ahead of his time. What he did is he had engineered this rapid response of medical care to the field with trained pre-hospital personnel, transported patients back, early aid station care, physician involvement all along the way. And this was an EMS system that was organized by, run by, and directed by a surgeon. Interestingly enough, the other thing that he's known for is really the first PIPS program, quality assessment of the care given. And this whole program that Larrey constructed was really considered to be the first modern military surgical field care. Then came the Civil War, or in due deference to my Southern brethren, the War of Northern Aggression. And this is what the Civil War ambulances looked like. Much like Larrey's time, during the Civil War, thousands of soldiers were left in the field for days, upwards of 10 days, and their death was miserable. And what happened was they had these field hospitals, they were transported, and one of my friends was looking at this slide, by the way, and he says, "Hey, is that you?" I get a lot of grief about that. But anyway, they provided care. If anybody, this would have been me over here, the guy with the cigar. But nonetheless, field care was not exactly aseptic. It wasn't exactly humane, but it was given. Transportation, if you want to talk about transportation between hospitals, it was by train. This is an example, a very nice drawing of a medical train on the Union side of things, transporting wounded soldiers north. And then the civilian world caught on. And in fact, the first civilian ambulance in the United States was at my old alma mater, or so we were told. In December of 1869, Bellevue Hospital formed the first ambulance service in New York at what was then called the Free Hospital of New York, now known as Bellevue Hospital. In the first month, that ambulance service serviced 74 patients. In the next year, they took care of 1,870 patients, which is actually double what was done in that first month. Control was not exactly as it is today. Today, the ambulance service in New York is, as you know, is FIDNY, the Fire Department of New York. At that time, the police, public services and charities, and the institutions themselves ran the ambulance service. A few years later, and you'll see this again, in JAMA, it was said that a hospital without an ambulance is a hospital without patients. That kind of makes sense. This is what the Bellevue ambulance looked like. This is outside of the old ground LICU. And again, one of my partners says, "Is that you?" Yeah, it could have been. But nonetheless, if you're a history buff, Bellevue was actually not the first ambulance service. The first ambulance service was a year earlier in 1865, and it was in Cincinnati. Cincinnati General Hospital actually had the first functioning civilian hospital-run ambulance service in the country. Grady Hospital, several years later, in 1892, I believe it was, Grady Hospital was built by Mr. Grady, and since then, this hospital has the oldest continuously operating hospital-based ambulance service in the United States. Now, this hospital decided to go all out. As those of you who know Grady, it wouldn't surprise you. A.B. Miles was a surgeon who designed this entire carriage. The carriage was actually built in Concord, New Hampshire. It was 1,600 pounds. It had 2 horses to pull it. The carriage finish was paneled wood lined with varnished maple. It was mounted on what was then called easy springs, and it had Charity Hospital in gold on the side of the ambulance. This was a fairly efficient system and had a very lavish interior with medicine chests, surgical tools in boxes, hooks for lanterns. It had an easy bed with a trundle system. You can roll the litter in and out, much the same as we see today. And there were separate springs for the bed. How things have changed. Let's move forward a 100 years or so. 1948, about 75 years after that Charity Hospital ambulance. This is what we were looking at when we were talking about an ambulance service. Interestingly enough, if you take a look at this vehicle, it's very reminiscent of a hearse, isn't it? Well, unfortunately, many ambulance services were actually run by the funeral homes. This is Bellevue Hospital, New York Fire Department, out of Bellevue. This is Engine Company 56, which is just down the road from the old Bellevue Hospital. And then moved to Korea. The first time that we actually saw Air-Evac was in Korea. And those of you who are fans of MASH have actually seen these evacuation aircraft. There was room for 2 patients. Unfortunately, this was a fairly dangerous way to roll. They'd transport them to wherever they were going. They'd put them in an ambulance and then roll them down to the field hospital or the Mobile Army Surgical Unit or the MASH hospital. The Cadillac Supreme. And for those of you who have served in Vietnam, I know Steve will recognize this dust off. Some of the most amazing pilots in the world would pick up patients in the field and bring them to the surgical units that were not too far from the forward lines. This is what it has turned out to be. This is your pre-hospital care and your hospital care in the field now, given 2003, the last conflict that we were involved in. These units could be quickly deployed, and within 20 minutes, you have your ambulance service now turned into a EMT or an intake and an operating room, which would then fly these patients after being stabilized to a combat support hospital with a side-by-side OR and a connex that would open up into these buildings. So we talk about inter-hospital transfers. It's kind of interesting. This is a C-17 Globemaster III. If you take a look at the plane, it is one of the largest cargo planes available in the world. And if you look in the lower right-hand corner of this slide, this is an aircraft that has just transported 4 Abrams tanks and is now a mobile ICU, a mobile hospital. So this is your inter-hospital transfer. This comes from downrange to Ramstein, which then goes to Landstuhl, which then goes from Landstuhl back to Konus, to the continental United States. So when you talk about inter-hospital transfer, it's certainly not what we know on the civilian side of the world, which looks like this. Now, let's talk about some of these Scudder orders. Back in 1939, Fraser Gerd started talking about the importance of training individuals in the management of trauma. Now, that's not just trauma surgeons, but that was pre-hospital personnel. He looked at trauma as a team sport. EMTs are a member of that team, and at least 1/2 of that famous golden hour is managed by pre-hospital personnel. The care provided by EMS should be directed and guided by surgeons, and I think we can all understand that although it says directed and guided by, I think that the partnership between surgeons and pre-hospital personnel, whether you're basic, advanced, or paramedic, the partnership must be an integral one, and it has to be one of cooperation and one of familiarity so that everybody knows exactly what the other fella is talking about. William Estes was a Scudder order in 1953, and he talked about trauma centers. This was probably the first mention of trauma centers. What is a trauma center? It is a hospital. And mind you, this is before the American College of Surgeons Committee on Trauma came out with the verification process. He talked about a hospital that should have the resources and the personnel with an appropriate fund of knowledge to take care of all of these trauma patients. I think it's important to understand that it wasn't until this talk was given in 1953. The verification process didn't start until Don Trunke really pushed it forward in the early 80s, and it became a functioning system with the first optimal resources book, and somewhere around 1990. Another Scudder orator, Preston Wade, talked about a surgeon who is able and capable of taking care of all traumatic injuries. And what he said, and I'll read this quote: "When an accident victim will be transported carefully by qualified personnel to a well-equipped and specialized trauma facility, and he will be properly cared for by surgeons trained in all phases of trauma care." One of the most important concepts that he put forward was that trauma is a surgical disease from the beginning to the end. Now, we're going to see this again, but when you talk about the care of the injured, from the beginning to end. We're talking about care that starts in the field. Care can't wait until the emergency department or the operating room. It has to start in the field. The pre-hospital personnel, emergency medicine technicians, medical technicians, whether they're, as I said earlier, basic, advanced, or paramedic, they are our, when I talk as a surgeon, our eyes, our ears, and our hands administering to the wounded, to the injured in the field. They need to work with us, and we work together. And the fact is, survival is a reflection of how well we have trained the EMTs and how well this team is constructed. Again, trauma is a surgical disease from the beginning to the end. So, if you consider that to be true, I think everybody is going to agree with me that the pre-hospital care is the beginning and usually the most important piece until they end up in the emergency department, because that's going to make the difference between life and death. 1992. This is the first TV show that really brought attention to pre-hospital personnel. Roy DeSoto and John Gage captured the imagination of the American public as they ran this show from 1972 until I think 1977. And America, the United States, the American TV public suddenly realized that it's not just the hospitals, but it's the guys in the field that are saving lives. And I think that that was the beginning of our concept of pre-hospital care being a critical cog in the care for the patient. Deke Farrington, who is considered the father of EMS in the United States, gave his Scudder oration in 1973. Have you gotten a sense that we as surgeons are focused on care before we ever see the patients? I hope you have, because what Farrington questioned was, why haven't we indoctrinated? Why haven't we taken the lessons that we've learned in World War II and in Korea and made them part of our civilian trauma care? When you think about it, and we'll talk about it later, somebody famous once said that if you want to be a surgeon, you need to go to war. We'll get to that in a little bit. But the fact of the matter is, Deke decided that we needed to incorporate all of these lessons that we have learned. And he established the very first 81-hour, quote, first aid training curriculum. That was the predecessor to PHTLS. It was the establishment of that course and a prototype of an EMT ambulance course. In other words, what these guys are doing in their rigs before they make it to the hospital, that made folks consider Farrington to be the father of EMS in the United States. Then along came this thing called PHTLS with the National Association of Emergency Medicine Medical Technicians, 1975. If you take a look at the folks on this slide, I'm happy to say that Jim Peturas has joined us tonight. Gary LeBeau and Rick Vamaka were instrumental. Rob Nelson and of course Norm McSwain sat down, put their heads together, and came up with this concept. What was the concept? The concept was ATLS for non-physicians. Now, this is before ATLS ever happened. So you want to talk about guys who were ahead of the time. Well, these five folks were truly ahead of the time. ATLS actually came to be in 1966 and 1976 and 77. For those of you who don't know Jim Schneider, Jim was a orthopedic surgeon. He was actually flying a plane in Nebraska and crashed. His wife was severely injured. I believe one of his children was killed as well. And his comment was, if I can get better care in the field, it would have made a whole heck of a lot of difference. The American College of Surgeons Committee on Trauma decided to take his thoughts and develop a course that could establish the care concept for hospitals. And it was first given in 1980 by the surgeons who actually developed the course. And if you take a look at this, there's Abrahamian over here, there's Jerry Strow over here, there's this guy named Norm McSwain over here. There was a host of guys who developed this course. And in 1981, after the first course had been given, there was discussion about having EMTs taking ATLS. Well, the regents, in their infinite wisdom and in their protectionist way of looking at things, said, no, that ain't gonna happen. ATLS is a physician-only course. EMTs can't take it. But the COT will support the concept of an ATLS-like course for EMTs. And what they did is they took all of the materials from ATLS and they took all of the materials from the Orange Book, which was the Emergency Care and Transportation, the National Standards Curriculum, and they came up with basic and advanced 3 sources to form this thing called PHTLS. The motto was judgment based on knowledge, and the emergency medicine technician's fund of knowledge should be developed and provided by the surgeon. Now, again, the concept was that this is a surgical disease. And I will tell you that although it is developed and provided by the surgeon in this quote, I think anybody who has ever known the folks who worked on putting PHTLS together, it wasn't developed and provided by the surgeon. It was developed and provided by the surgeon in concert with the guys who actually have boots on the ground in the field. And I think that's an important thing to remember. PHTLS actually came to be in the Richelieu Hotel in New Orleans. The folks who looked at this process and tried to bring it together, Jim Paturis, Bob Nelson, Rick Vamaka, Alex Buttman, Jeannie O'Brien from Idaho, I believe, Ann Bellows from Massachusetts, Joe Deneen from Connecticut, and Norm McSwain all sat down and said, okay, we need to put this course together. We need to make a standard for pre-hospital care, much the same as ATLS has set the standard for hospital care. The pilot programs got going, and I have to say that 4 places gave the pilot course: Tulane, Marion Health in Iowa, Yale University in Connecticut, largely because of Joe Deneen, and Norwalk Hospital. Now, at the time, 1982, I had just left my residency program at Bellevue, and I had just taken over the trauma and the ICU at Norwalk Hospital. So I actually sat in on this pilot program that was given in Norwalk, having no idea exactly where this was going to go. And I would hope that after I'm done talking, we can get some input from Steve and from Will and from Jim on exactly how all of this really developed, because having not been there, I'm just giving you what I've been able to glean from the literature. ATLS for non-physicians. Again, these guys sat and put it all together. It ended up being drawn on a bar napkin in the Frontier Lounge in Las Vegas in 1983, and the concept extending the hand of education to those who care for trauma patients. That was PHTLS, pre-hospital trauma life support. National faculty course was put together at Tulane in 1983. Again, the same folks, all of whom had bought into and truly believed in this process. And I think that it's important to note the leadership of the late Dr. McSwain, the late Dr. Deneen, John Quinlaven, interestingly enough, and I just finished working together. John retired as a director of pre-hospital and EMS liaison at St. Francis. I've known John since 1982 when he was also at Norwalk Hospital. The textbook came out in 1984, Phoenix Park Hotel, and you can take a look. You get the idea that the same folks who were passionate and dedicated to the development of PHTLS were working on all of this. Will Chaplot was in all this as well. Steve, I believe you had a hand in this. So, you know, PHTLS took its birth from folks, surgeons and paramedics, who truly believed that this was a team sport. So now let's take a look at the stages of EMS care in the United States. How did this really evolve? No care and rapid transport. You were randomized to no care before 1950. It was basically you're thrown into a hearse, aka ambulance. Scoop and run concept was what this was all about. Subsequent to that, between 69 and 75, field management and care en route was the vision of a lot of surgeons and pre-hospital personnel. And after that, patients were treated like a cardiac patient with prolonged scene time, that stay and play concept from probably about 75 to 85. That matured. Definitive field care for the trauma patient was stabilize and transport, aka close to scoop and run, but more treatment is being delivered to the trauma patient in the field. And we'll talk about that in a little bit. Major changes in resuscitation came from the military to the civilian world, and these were instrumental in our ability to change the way we take care of patients in the field because of the teachings of PHTLS and what we learned at war. We assess the scene in the patient. You keep the scene time as short as possible. If necessary, you establish an airway. And I must say that establishing airways in the field is now a matter of debate. And I don't think I'm going to get into that today. Controlling hemorrhage, stabilizing fractures, packaging for transport, and continuing care en route. IVs is necessary, ventilation is necessary, et cetera, et cetera. The key is to transport the injured patient to the trauma center whenever available, or the closest appropriate medical facility. This is a wonderful quote. Rick Bell was a past chair of the ATLS committee, and I love this quote because this says it all about us as surgeons and the pre-hospital personnel. It is easy for us to practice our craft in the warmth when it's cold outside, dry when it's raining, cool when the sidewalk can fry an egg. Pre-hospital providers are not so lucky. The floor of my resuscitation bay or my OR does not bump and sway over potholes or rounding curves as I'm trying to start an IV, put in an ET tube, or provide CPR. I think that summarizes the difference between what I do in the hospital and what our pre-hospital personnel do and are faced with when they're trying to render care. Obviously, the key principles to use were oxygenation, hemorrhage control, do no further harm, and alleviate pain and suffering. That's our oath. We all take that same oath, and we need to remember that. We also remember the triangle of death: acidosis, coagulopathy, and hypothermia. These are the three bugaboos of trauma, and you put all three of them together, and mortality is exponentially increased. Knowing this, the history of EMS and trauma care has been directly related to war. Most improvements that we've seen in the way we take care of patients have occurred during a conflict and then have been brought back to us after that war and have been translated from the military into the civilian world by astute, well-learned, and well-respected surgeons. I mentioned this earlier. He who desires to practice surgery must go to war. This is nothing recent. This was said by Hippocrates a few thousand years ago. And I think that it is very, very astute to remember that, because patient care does not begin in the hospital, but rather the fate of the wounded rests in the hands of the one who applies the first dressing. Now, for those of you who don't know Nicholas Sen, he was a Austrian-born surgeon who came to the United States. He practiced during the Cuban-American War. He is, interestingly enough, the founder of the Association of Military Surgeons of the United States, founded that organization in 1891, and he's a previous chair of the of the AMA. So the guy was well versed. He was well respected, and I think that this quote to me says it all. It typifies what we need to remember about pre-hospital care. That pre-hospital care must be followed by rapid delivery of the patient to a facility capable of providing appropriate care. I don't care if it's Luray's flying ambulance or today's modern aircraft or a troop transport. Any way you look at it, we've got to bring the patient to the appropriate facility. Now, something that has come to pass since this last concept is hypotensive resuscitation. And I think a lot of our EMS colleagues are now beginning to understand this concept. And I wanted to mention it today because I do believe that it is a very appropriate and frankly life-saving concept, because while we're perfusing the heart, lung, and the brains, for most of the patients that we take care of downrange, perfusion is adequate with a blood pressure of 80 to 90. This is, however, age dependent. And it is why very frequently you'll see in trauma centers, there will be two activation levels. There's going to be a blood pressure of 100 or below, 90 or below for the young, or 110 or below for the elderly. So remember that this hypotensive resuscitation is age dependent. The whole concept of this was promulgated by Ken Maddox, who said that if you increase the blood pressure in a hemorrhaging patient to normal, if they have had the opportunity to form a clot and cease the hemorrhage, you're going to, as he said, pop that clot. And so you need to remember that because hemorrhage is the most common cause of death in the injured patient, this is an important concept that has recently come to pass. Treatment of hemorrhage has evolved over the last 20 years with the ability of giving blood in the field and TXA if it's available, the appropriate use of tourniquets, rapid transport to the trauma center, experienced and available trauma personnel, blood, plasma, and platelets in a 1-to-1-to-1 ratio, whole blood available not just in the hospital ED, but if you take a look at this, many centers are now sending their aircraft and their ground ambulances out with whole blood in coolers. And they also have thawed plasma available. The quick availability of invasive radiology is an important adjunct, and an immediately available operating room so that we can treat these patients with vitamin S. And if you don't know what vitamin S is, that's surgery. The National Academies of Science, Engineering, and Medicine came out with a national trauma care system. This was at the height of the last conflict, 2016. A lot of us had come back from downrange with a whole host of changes in the way we were able to care for patients. We wanted to make sure that we integrated military and civilian trauma systems so that we could achieve zero preventable deaths after injury. In other words, what is the best way to take care of the patient in the field by those who are applying the first dressing so that we can get them to the trauma center and save lives? The quote at the preface in this document was interesting. And if you think about those Scudder orators that I talked about earlier, Brent Eastman gave his Scudder orator about throwing a dart. He said that the American public should be able to throw a dart onto a map of the United States, and anybody within 60 miles of that dart should have immediate medical care at a trauma center. So what it says here is when it comes to trauma, Where you live ought not to determine if you live. It is time for a national goal owned by the nation's leaders, 0 preventable deaths after injury. That means the availability of everything that we just talked about a little bit ago for every citizen living in this country. This document came out a year after Norman died, and it was therefore dedicated to him because of his leadership in putting the document together. And as you know, Norm was prior service. Many of the folks who worked on this were prior service, and it was a joint concept between the military and the civilian worlds that brought this document together. Norman was instrumental in making it happen. As such, I want to thank you for the opportunity. I did, knowing that Jim and Will and Steve were going to be on this, I did want to cut it a little bit shorter than I normally would, because I would love to hear from them. Gentlemen. Uh-oh, we lost Will. So, if I could.
You got Patoris.
Jim.
Thanks, Steve.
Good evening, Jim.
Who's that white-haired guy?
Who's the white-haired guy with the beard?
Who's the no-haired guy with no beard?
That's true. We won't go there.
So, Jim,
sure.
You were at the bottom. You were at the beginning of this whole PHTLS. Steve and Will were there. Unfortunately, a whole host of the other folks that I was referring to in my discussion were instrumental, but unfortunately have left us. Can you guys fill us in? And as I said, I have cut a whole bunch of slides out of this because I thought the three of you guys could really enlighten us as to the real meaning, the real impact, the real development of how we came to have PHTLS and what a difference it's made in our ability to care for our patients pre-hospital.
Oh, sure. I mean, I guess I'll start, but I'll let Will and Steve chime in as either I'm telling lies or I've lost my mind. So I think everything you said, Ron, was right on target. I mean, in terms of, how it all started, for those of us who had the privilege of being on the ground floor, I will say, and it goes along with many of the things you mentioned in your lecture, it really came because of the surgical relationships we had. So you mentioned Joe Dineen here in Connecticut. The reason we got 2 pilots was because of Joe Dineen and Alex Buttman. And in Iowa, it was Don Boyle, who was state chairman out there. And of course, in New Orleans, it was, or as Norman would say, Nolans, it was Norman's. It was Norman. It was, he, and I think he clearly was a catalyst for this program. I will say this, having been involved for a long time and also then going on to become president of NEMT, this was shoved down NEMT's throat. And it was shoved down there by Norman. And had it not been, I don't think either NAEMT or PHTLS would be where it was today. And more importantly, what PHTLS, and you and I talked a little bit about this earlier today, really was developed for. In the most altruistic way, it was really done to better care for patients and to improve those of us who worked in the field. And of course, then the handoff to all of our hospital colleagues. To NAEMT, it was a cash cow. And that's not a negative thing. It just was. I think what it did for NAEMT was to show them that the value of putting together standardized education that they could market all over the world. But the bottom line is that this program would not be here without Norman. Pre-hospital trauma life support. You could argue that it was followed up by the American College of Emergency Physicians with BTLS. Those were very interesting days in the early days of the competition between the surgeons, the emergency physicians, and then all of the EMS people in the middle. I will stop there and let Will and Steve chime in. But I remember when both of these guys came in and they were just such valued and continue to be valued team members for the PHTLS. And I think that's another thing for all of you to remember, is that PHTLS became generational. It really did. And it was very positive in its generations, in that we all became converts. We were all disciples. And I like to say disciples of Norman. And, you know, I'm proud to have become his friend. I'm proud to have stood next to him in many places. And I think we're a better society because of people like him. And of course, what he helped do with trauma care.
I'll defer to Steve first, and Jim. You and Steve were in it before I was. As a matter of fact, my involvement didn't start till 1984, and then I kind of took a nap until the 90s when you brought me back in to put out fires. But early on, like when I first started showing up, Steve was already there. Steve, do you have some memories of how the development of?
Well, what I wanted to say is the idea that about PHTLS is PHTLS was the first time that EMS was brought into the fold directly with the surgeons in between there. And I think that that had a very, very big positive impact on the relationship that EMS had in the care of the trauma patient. In there, we were being asked by the surgeons, you know, what is it that you can do that can help make things better for the outcome of the patient? And I think that it's, I'm very happy to say that I think we made a big difference in the care of the trauma patient and increase the survivability in there. And with the education that was provided worldwide in the relationship, not just with PHTLS, but with all the standardized education, everything that has, that it came about. But it was again, it was a recognition of being a team approach to things that I think that really set things up. And this was one of the best one of the best ventures I, you know, in the 80s that I saw that came about. That, I mean, matter of fact, that's how those of you that know Norman, when I took the class the first time in the early 80s, I had a couple comments about it from an educational standpoint. So I wrote Dr. McSwain a letter and everything, and he says, "Good, fix it here."
Yeah, that's yeah.
Yeah, and those of you that, and
We're all
again,
gonna fix this. That was
yeah, we're going to, how are you going to fix this?
Yeah.
Between there. And I think it had an impact again on, I know it had an impact on the way that I approach trauma care, as well as education of EMS providers and everything throughout my career in there.
I guess I would add, Jim made a comment that I think was kind of prescient. It's and then I'm going to move on to other things, because PHTLS is a part of our EMS history, but it's a part. But at that particular point in time, Jim mentioned disciples, and it was very much a group of disciples or apostles, and then there was a new idea, and that we thought we were onto something, and then we pushed it out, and it became something. And I think we find ourselves now at a crossroads, or not a crossroads, but a continuing evolution or development. And it's like, what's next? You know, it's like, you know, we can always look to learn from what we've done. But where we start to collapse is when we keep thinking that we just keep doing the same thing. And I think we're evolving now to, I think we all learned during COVID that education's changed. And I don't know that it's ever going to go back to where we were. It's very difficult to get people excited about live training. Continuing education has to continue. There's new material, you know, the literature is teaching us new things. It's how do we get that to an audience that is not sure that the existing models work anymore? It's going to be challenging. And even more so is the world of publishing and education and training going to have to adapt to a more dynamic mode, so that the kids that we're training now to be in EMS compared to us are more used to instant availability of information that they can apply right now. We are not set up to provide that educationally yet. There are other mediums do it for other types of things. So their expectation is, if I need to know this, I can get at it. And we haven't adapted as well or as quickly. And I think that's going to be the next thing that we do. I think this has been a great discussion about history. But I think what we learned from it is that people stepped up into a void, or not a vacuum, because there was stuff, but into a void or an open or a fissure, and then said, this is where the opportunity is for us to progress forward. And I'm sorry if this sounds kind of vague and less direct, but I think we're on the verge of something different. I think the world of education and training is going to change. I think certainly, Ron, the stuff that we're learning about trauma surgery, even, I mean, when you think about what you do in trauma surgery today and what you were doing 10 years ago, there's procedures you wouldn't do anymore, right? I mean, stuff is where it's evolving.
One more, and I want to go back and just make one more comment about that. I think that you're right on there. I think that one of the things that we learned from Dr. McSwain and everything is that the care we give today may not be the care we give tomorrow. Things change, and we have to be able to maintain and keep up with it. And that was one of the things about that. And it needs to be based on science versus personal opinion and preference in things. I think that's, I think that helped out tremendously. Dr. Gross, go ahead. I'm sorry.
So no apologies. The fact of the matter is the things we do today will not be what we're doing tomorrow. The things that we do today have been based on what we've learned from science, because when somebody says, well, we've done it that way and it's worked just fine, so why change? You know you have a problem. We are obliged to look at the science and to look for better ways of doing things that may be completely different. I mean, who would have ever thought 20 years ago about maintaining a blood pressure in a wounded patient at 70?
Yeah.
That was heresy.
Yeah.
And yet the lives that new concept has saved is amazing. Ken Maddox used to call tourniquets the instrument of the devil.
Yeah.
And yet the number of lives that tourniquets have saved, appropriately used tourniquets have saved, is just simply amazing. We must move forward, and we must move forward, as you said, Steve, based on science. We can't forget the past. We need to look at what we've learned, what we have to forget, and what we need to look at next.
It's interesting. You should phrase it that way, because the mask suit, which is one of Norman's favorite devices, disappeared because of the lack of science to support it. But many of us used it and could anecdotally tell you about situations where it seemed appropriate or even saved a life. And now elements of it are being reapplied into different devices. So stuff, it all comes around. We have to learn what we learn, but then again, make sure the application is appropriate, and then we keep challenging ourselves to look forward.
If you look at a map of the United States, and I saw in one of the chat comments that there are some areas that can't field a crew for a rig. I will tell you, I live in a town of 16,000 people. It is the largest landmass town in the state of Connecticut. We have an ambulance company in this town that is unstaffed about 20% of the time. So I understand that concept. Sadly, we're not going to ever be able to get to what Brent Eastman wanted to see. So I think you're right in that we're going to have to redesign the way we provide pre-hospital deployment.
That's why systems are important, right? I mean,
exactly.
And by systems, we mean that rural has to have a voice in regional conversations about how resources are deployed, and about how we manage the way we get people and take care of them so that they can make it ultimately to definitive care. But what do we do in the interim?
And that's where the RTDDC, the Rural Trauma Team course, is so important. It will train not just the hospital personnel, but those who are coming into the hospital in the most efficient management of the assets that you have, both disposable and personnel. And I think that the rural areas have to look at that. And I'm happy to see that there's a newly born emphasis on rural trauma in the COT.
Well,
Yeah.
it's amazing. I just looked up a little fact from the American College of Surgeons. They say just 20% of those who live in a rural area have access to a level 1 or level 2 trauma center within 1 hour, while 86% of suburban and 95% of urban residents have a timely access.
Correct.
There are states in the United States, and this be a surprise to some of our audience, that have no level 1s. None.
That is correct too.
Yeah.
So it's a reality of where you live. Jim, I kind of stepped on what you were talking about as far as the history of the development of PHTLS, but any thoughts on yours that we're looking for like the next wave or an evolution of how we do this stuff?
No, I mean, I like some of your thoughts that, you know, we do need to change with the times. That's one thing. I think what's probably personally distressing to me, and, you know, and you three gents know that I, over the years, migrated more into what, you know, people would call emergency management, disaster preparedness, but I still maintain my paramedic, and I still, of course, am very involved with them. But here's my point. After many, many decades, as you all have been involved, the sad part for me is that I'm seeing similar issues still come up in EMS. You've talked about some of them here tonight, you know, lack of access, distance, not enough people, inconsistencies in care, inconsistencies in access to care. You know, we're still seeing hospital diversions. Now, they may be different reasons. You know, I remember when I was on the street back in the 70s and we had hospital diversions. Well, damn, we're 40 years later. And I'm seeing the same thing in emergency management. And it's a bit distressing to me. And maybe it's just and maybe it's sort of like the weather, as they say, it's just recycling over time. But I'm okay with recycling if you're improving. And I think we are, but I just am a little wary that some of the same issues continue to surface. And I think we're doing a better job on advocacy, but I would say that's a huge issue. That is a big gap for all of us. We are our own worst enemies in that we do not sell the scope, depth, and intensity of the services we provide in enough people to warrant their both financial, legislative, and political support.
That's a good point. And Ron, within the scope of what you talked about, and I know we're running late, so those of you that are hanging in there, thank you for staying with us as we go a little bit over. But one of the things that we struggle with, both with the nonprofits that we work with and some of the other projects that we work on, and to Jim's point, is we kind of seem to be losing this, the disciples, as Jim talked about, these are volunteers. These were people that did stuff. They were not paid. They did it because they believed in it. And we seem to be having trouble. And I'm not sure, it's probably a little both, but I'm not sure if it's our inability as the aging white hairs and no hairs on our way out, not being, sorry about that, not being able to recognize the talents of the folks coming behind us, or if they're just not there. We seem to be having a volunteerism problem, which reflects in your services that can't get coverage. The small volunteer departments, which cover the depth and breadth of this country, most of this country is still volunteer service. You know, are we running into an issue here with the loss of this age of volunteerism?
There's no question. And I will tell you flat out that it is a combination of, and every older generation dumps on the younger generation.
That's our job.
What it's always been. It'll never change. But the fact is that volunteerism is waning. And I think that there are two things that are lacking. It is the understanding of the younger generation about what their capabilities are. And it is the lack of the no hairs and the white hairs in working hard at mentoring and motivating those folks. I think if we really put our mind to it and we made kids, and I'm talking kids, you know, I'll be 73.
I mean, people in their 40s, right?
Exactly. we convince them that A, they are important, B, they have the ability and the knowledge, and C, they are desperately needed. We need to show them why they're desperately needed, show them how they can be used and how they can use their talents to make things happen. That's mentorship.
Yep.
And I think
Right,
that
but also
we
another
have to do
facet
that.
of that also is the general public has to understand that and has to be supportive of it also. In between there, that's one of the things, you know, they say, well, EMS is an essential service. Well, it is an essential service, but it needs to be supported. In between there, it takes individuals to step to the plate in order to do that. I know. So, oh well, like I said,
We just had a good comment from Michael. It said, have we contributed to the loss of the age of volunteerism by continuously increasing the requirements in order to be able to practice? And this is something those of you that have been on these for a while or know me for a while, I preach about how simple things can really be. And it may be that we jumped too far to the advanced and made it difficult to provide basic service for people when basic service is what most people need. And it may be that we have to rejigger, what EMS is and what's needed. Because for the most part, it sounds like advanced life support is very targeted, very specific, and maybe we can do it without the constraints that systems place on volunteers and small communities to be able to comply with the standards or requirements. It's a big question. It's a big argument, but I think the care that we give, and again, the white hairs in the group besides me, I'm not the only one here with white hair. Remember when we started, and we made big differences right away without being that complicated or that technical.
You know, Will, I've been reviewing for the COT, for the VRC for about 18 years. I've gone through from the very first Optimal Resources book, because I brought Norwalk on as the first level 2 trauma center in Connecticut. And I've watched that process develop over the last 30 years. And you go to hospital after hospital, this whole verification process is a voluntary process. If you want to be a level 1, you work to be a level 1. If you want to be a level 2, you work to... The point of the fact is that there came a time when hospitals were choosing not to re-verify because it had been made so difficult by the VRC. The VRC got an idea that we need to change things up. And I think that we have perhaps moved the pendulum back just a little bit. But I think you're absolutely right. You know, your talk, is it that simple?
Ron, you just stumbled into something.
Envy.
Very basic, all the way on to education, remediation versus failing somebody. It's like when you have a student in front of you that fails what you're trying to teach them, send them out the door with a failure or remediate them, because they're still doing the work. You know, whether you pass them or not, they're still doing the work. So what's the most important thing to do? To try to get them closer to the point of compliance, or just to say no and send them out the door? I mean, it's funny. It's a very simple conversation that's expanded into all these other things. But I think it's important to consider all these things when we try to figure out what do we do with dwindling resources, places where resources are woefully inefficient, and how do we keep people involved and excited and inspired? It's
well, maybe one last way we can close this off with Norma's mantra. What have you done good for mankind today?
Yeah.
And that is,
did we time out?
If you think about volunteerism, you know, if you could get people to believe that and really believe it, I think you could see some change.
I had put that slide in. It was my last slide. And in the interest of time and wanting to get this discussion going, I had taken that slide out. But Jim, you're spot on.
Yep. All right. In the interest of time, we are getting a little bit over. I did want to, Jim, you made one comment, about how we have tendency to still fight the same battles and everything. Go read the 1966 disability paper. They came out, the white paper in 1966. The challenges
Accidental
that were
death and
identified in
disability and neglected
1966.
disease of modern society. Of
Yeah,
course. I have
Still is.
I have an original copy too,
yeah. Unfortunately, so do I.
along with Death in the Ditch.
Right. But those challenges are still out there.
Absolutely.
They're still out there.
I mean,
And
the whole
also-
trauma center stuff is still out there, and we can't even get bed determinations and bed naming conventions the same, for Christ's sake.
We can get huge resources for cancer and stuff like that, but we can't get it for trauma.
Yeah.
Again, it goes back to that advocacy. I know we have to go. I was sitting in Atlanta a number of years ago with the CDC and others and ASPR and back all then. And it was so interesting. The NIH came up to give a talk as an update. And what was so interesting about the NIH is what they said to everybody in the audience: you need to follow what we do. The reason we continue to get the funds is because we know how to market ourselves. We know how to go out and get advocacy. And they do. And that's something we need more of.
You know what? Let me just close this with an old expression from the Army, and it applies so much to today. We've done so much with so little for so long that they now expect us to do everything with nothing forever.
Yeah.
We are at that point in medicine, and we need to reorganize, redesign, and re-recruit.
Pretty much. And it's probably fair. I appreciate so many of you have stayed on. There's still almost 40 of you folks still here, and I appreciate that you stayed longer with us. And Ron, I want to commend you on leaving your conversation open enough for us to go in these other directions, because it was kind of fun when we started talking about these other things, because history is most important because it gives you the background to figure out what you have to do next. And I think the fact that we've had a significant discussion here at the end about what we do next, I think bodes well to that understanding of history. And I want to thank you for bringing us to that point tonight. Jim, thank you for pitching in tonight. It's good to see old friends that of the disciples. Here we are in the next phases of our lives. Steve's always here with me, so I appreciate that.
I got to get the red robe next time, though.
Okay. All right. Well, again, thank you, everyone.